Good evening for participants from India, and good morning for delegates from many other parts of the country. I invite you to the fourth webinar being conducted by the Endoscopy Society of India, and this in this month we are doing in collaboration with the WFNS Education Committee. I'd like to thank the chairman, Professor Borwa, who agreed to participate as a collaboration webinar with the National Endoscopy Society of India. And so we have two speakers on behalf of WFNS, Professor Arthur Cunha, who is president of Brazilian Society of Pediatric Neurosurgery, and he's in the editorial board of the Child Nervous System, as well as he's president of the Latin American group of studies in neuroendoscopy. He also has a lot of credentials, but I'll not go through everything. And then we have Professor Sufianov. He is the chairman and director of Department of Neurosurgery from Taiwan, Russia. He'll be joining us in a few minutes. And we have a panel of galaxy of panelists. We have Professor Neelam Venkatramana, who is director of Brain and Spine Center SPARS from Bangalore, India. He was earlier faculty at the National Institute of Medical Science at NIMHANS, Bangalore. We have Professor Suresh Shankla, who is director of Department of Neurosurgery at Global Hospital, Mumbai, and he is ex-president of the Endoscopy Society of India. And we have Professor Deva Pujari. He's a current chairman of WFNF Endoscopy Committee, as well as he is the head of the department at Department of Neurosurgery at Bombay Hospitals. And we have Dr. Pathak, who will join with us as another panel member. We have three other speakers who will be presenting cases. Dr. Anshu from Global Hospital, and Dr. Tyagi, assistant professor from NIMHANS, Bangalore, and Dr. Chandrasekhar from KIMS Hospital, Hyderabad. Me and I'm with Dr. Subodh Raju, who are moderating the session on behalf of the Endoscopy Society of India. Dr. Subodh Raju is director of Department of Neurosurgery at EIG Hospital, Hyderabad. We'll have the first lecture by Professor Cunha, followed by three case discussions, where we'll seek opinion from the panel members, and followed by the lecture by Professor Sufianov. He is stuck up in a case, but he has promised that he'll come and join. With these few words, I request Professor Cunha to please share his screen and start his presentation. I request all participants to please write down their questions and answer in the chat box, so that at the end of the presentation, the panelists can discuss and answer the questions also. Professor Cunha, please share the screen.
Okay. So. Okay, did you see my, all right, that's the moment.
Yeah, it's seen.
Okay. It's okay now?
Yeah, yes.
Yes. Okay, good. Then good morning and good afternoon, wherever you are. I appreciated the opportunity to be participating in what for me is the last meeting of the year. The neuroendoscopy has greatly expanded its frontiers in the treatment of interventricular pathologies. We are going beyond ETVs and biopsies, and many procedures are being performed increasingly safer and with good results. I do not intend to make a conference, but just a conversation about septostomy, fenestration of septum pellucidum, and other membranes. Let's make a quick anatomical review of the lateral ventricles, identify some important landmarks. Here we have an endoscopic view of the frontal part of the right lateral ventricle, where we can identify anatomical structures important for interventricular navigation located anteriorly. You see here the foramen of Moro, the septum pellucidum, and the anterior septal vein, the column of the fornix, and the genu of the corpus callosum. As we can see in this slide, few and thin arteries branches are visualized on the ventricular surface. Some authors have even stated that there are no arteries in the septum pellucidum. The anatomy of venous drainage varies greatly, but in general, we have regularly identified the anterior septal vein, which together with thalamostriate vein and superior choroidal vein empties into the internal cerebral vein at the inferior margin, this is medium inferior margin of the foramen of Moro. Sometimes we can also identify the presence of a posterior septal vein. Mini note, we can also see here a segment of the choroid artery that must be cauterized when we want to optimize the cauterization of the choroid plexus. Septum pellucidum, as we can see here, is a thin structure in the midline between the two lateral ventricles formed by two laminae, limited superiorly by corpus callosum and inferiorly by the fornix. During the endoscopic procedure, we can find an intact septum pellucidum, but in case of hydrocephalus, it may be translucent, fenestrate, or completely absent. The anterior septal vein can be large and single, but it can have several branches, both anteriorly and posteriorly. There is no consensus on the best location for a septostomy, also because it also depends on the objective to be achieved. In the bilateral cauterization of the choroid plexus, I prefer to look for an avascular area posterior to the anterior septal vein, 1.5 centimeter above the foramen of Moro. Before doing the septostomy, that is very important. It's very important to know the exact location of the septal vein on both sides, because the trajectory on one side could differ from the other side. Then you can have bleeding if you don't care about that. Here we have a list of the basic instruments used in septostomy in general. I have no experience with flexible and neuroendoscope. I have been using a rigid endoscope model NIMOP from iScholar because it's thinner. Some colleagues in Mexico City have extensive experience with flexible endoscopes. However, I see imaging quality as an issue with flexible models. This can be an important limiting factor in the approach to, for example, multiseptate hydrocephalus. Despite some controversies, I think a neuronavigation system is essential, very useful in defining the Bohr point, endoscope trajectory, and approach point. It allows us a safer and more effective surgery. The different models of bipolar as well as the laser are useful in septostomy and hemostasis. The use of transoperative ultrasounds, as we can see here, allows real-time imaging control, very useful in some situations such as multiseptate hydrocephalus. Fogarty catheter, is a balloon catheter, are used to enlarge the ostomies. So, about indication, septostomy is indicated in case of direct or indirect obstruction of the foramen of Moro, which may be closed or even absent in case of malformation. Foramen of Moro obstruction can cause what we call an isolated lateral ventricle. One of the ventricles remains normal, draining through the aqueduct, while the other is compartmentalized and dilated. Of course, the endoscopic approach may seem easy via the dilated ventricle, but with the help of neuronavigation, it's safer to approach via the smaller ventricle with less risk of contralateral thalamic and basal ganglia injury. Some hard case of huge septopellucidum cyst with foramen of Moro obstruction can be resolved with fenestration and communication of the cyst with the ventricle. I only had one case in my experience. Multiloculate or multiseptate hydrocephalus is a major challenge for pediatric neurosurgery. Fenestration of multiple cavity requires planning and use of neuronavigation and intraoperative ultrasound. Transoperative ultrasound is an important tool in identifying change in the anatomical path during the procedure. And as I said before, most of the septostomy I performed was to access the coagulation of the choroid plexus. So here we have the protocol for a careful neuroendoscopic approach. And I would like to show you some videos about septostomy and fenestration. As you can see here, you have the septal vein, the anterior septal vein, we usually do the septostomy with bipolar or with laser, and delete the ostomy with Fogarty catheter. Normally, we use the Fogarty catheter number 4. It's the same that we usually use in the third ventriculostomy. So in this short video, and here we have
recording in progress.
A case of hydrocephalus, where we first, this is an infant. This is 8-month-old boy, where we first performed ETV, then coagulation of the choroid plexus of the right, and we did the septostomy. With bipolar. So in this video, we have an example of multiseptate hydrocephalus. This patient was transferred from another hospital with a history of shunts and multiple revisions. He had 4 implanted shunts. And again, with foregut catheter. We dilate it. And we go with endoscope to the next cavity. And open again. After fenestration of the walls, the multiple cavities, it was possible to put only 1 shunt. So, to conclusion, endoscopic septostomies and fenestration involve abnormal anatomy, often with the complete absence of landmarks. These are procedures that require knowledge and experience. And finally, I wish you all a happy Christmas, and I hope that we will be closer next year. Thank you very much for the attention.
Thank you, Professor Kuna, and for showing us multiple indications of septostomy and very good videos and procedural demonstration of the technique. I'll request, I don't see anything in the chat box, but I'll request the panel members to give comment and ask any questions if there. Professor Borbas, Professor Deva Pujari, Professor Pathak, and Professor Venkatramana.
Well, I think basically, especially when you are dealing with a situation like multiloculated hydrocephalus, and you showed a very nice case, but even otherwise, how do you decide on the trajectory? That is number 1. And if I missed it, I do not know. Do you place burr differently than what you would do for an ETV when you are doing a septostomy? So one is point of entry, second is trajectory. Could you throw a little more light, and what is your guide for these?
Normally, if I plan to do the septostomy, my choice is the same approach as ETV, because it's not a big problem. If we use the bipolar, because you can open we can do the septostomy, we can open the septum pellucidum with in the lateral with a bipolar. It's not a big problem, and then I prefer that because I have a very good view for entire plexus choroid. We can very good the plexus choroid coagulate. There's no problem. But of course, if the goal of the surgery is only the septostomy, we can have a more lateral approach. But normally, the same as we usually use in the third ventriculostomy, I think that is enough. That is really safe.
Arthur, can I ask you a question?
Of course.
Yes.
It was a wonderful presentation and demonstration of the technique. So nicely, you really summarized everything for septostomy. I would like you to make some comments on doing a septostomy when there is cavum septum pellucidum, which you have mentioned earlier on your slides. When there is cavum present, what precautions do you take to make a successful septostomy? You got my question, Arthur?
Yes. We
Can I interrupt? Before you answer, can I request Dr. No. Before you answer, I'll request the next presenter to share his screen so that we save some time. Dr. Chandrasekhar, can you please share his screen? Dr. Kuna, please answer. Yeah.
So, sorry, can you ask again, please?
When you do septostomy in
Yes.
a patient who has cavum septum pellucidum, the cavity in the septum pellucidum, how do you perform the procedure?
Yes. Okay. Then it is necessary that the approach is more lateral. Yes. Then we can make the fenestration for one side, then through the cavity of the septum pellucidum, then you go to the other side. But as I said before, it is important that we have before the opportunity to study the septal vein both sides, because you can have a bleeding of the other side. Yes.
Okay.
Yeah.
Thank you.
To the NMR.
Professor Arthur, is it mandatory that pass the endoscope across the septostomy to confirm the entry into the ventricle, similarly like septum pellucidum, cavum septum pellucidum, as well as the presence of bleeding, or is it not necessary?
Oh, I think it's not necessary. It's not necessary. Okay. Yes, I never had problem with it.
May I ask something here?
Yes. Oh, Baba. Hi.
Just a curiosity. Okay.
Yes. Oh.
Looks like a big hole. Okay. How you know that this hole, this fenestration will be enough for the communication? Because when you do the third ventriculostomy, you can see that the flow is going in and out. But with the fenestration, how do you know that this fenestration is big enough? And what's the trick to be sure that it's big enough?
Oh, that is a very good question. Normally, is not like as we can see as we do the third ventriculostomy. It's not so easy that we see the flow of, or if the fenestration is big enough. Yeah. But normally, when I do half centimeter or a little more than half centimeter, and I think that is enough. But there is case that we needed to open again later on because closed. I never had cases like that. But in the literature, there is case that the people describe that the fenestration was closed after sometimes.
Question.
Thank you.
Can I ask one question? Yeah.
Last question by Professor Pathak, then we go to the next presentation, please.
Yeah, I'm sorry, there was some problem with my connection and I got late, but if I've heard correctly, you also mentioned about doing choroid plexus fulguration through the septostomy. If that is true, any special tricks to do that through the septostomy? I mean, how do you manage to do the other side?
Sorry, I didn't understand.
I joined late, but if I've heard correctly, you do choroid plexus fulguration through septostomy. Is that right?
Yes.
So, is there a technical trick in that? Because going to the other side and doing choroid plexus fulguration might be a bit of a challenge. So, anything you want to mention about that?
Yes. You think about the plexochoroidal cauterization?
Yes.
Okay. Yes. I really routine do the plexus choroidic cauterization in the hydrocephalus infants case. Yeah, because this is a group that the third ventriculostomy alone don't work very good. Yeah, the approach is the same as we do if you want to do the third ventriculostomy. Yeah, then we do the cauterization. We start in the forum of Moro, and sometimes if the forum of Moro is big enough, we can entry and coagulate the plexus choroides inside the third ventricle. Then we go to posterior part. Yeah. Then the septostomy behind the septal vein and 1 or 1.5 centimeter above the foramen of Moro. So we have a very wonderful view of the plexus choroid. Then we do the same. We start in the margin of foramen of Moro, the coagulation until the posterior part. Yeah, of course, depends how far we can coagulate the choroid plexus, because this part that go in the temporal horn, this is impossible to coagulate. But it's very important, as I said in my presentation, that we try to coagulate the artery. There's a big artery in the choroid plexus. So we had the opportunity to operate the patient a couple of months after the coagulation of the choroid plexus, and we saw that the rest of the choroid plexus is atrophic.
Right.
Yeah.
Thank you.
Thank you, Professor Kuna, for addressing all the questions. And there may be more questions in the chat box. Please do answer in the chat box. The next presentation is something related to what Professor Kuna presented, that when you have septostomy doing for foramen Monro block or multiloculated hydrocephalus, many times it's difficult to we plan to place a catheter which try to cover all the cysts or both the ventricles, and we have found difficulty in placing the catheter. So this is a small technique how to do it easily, which Dr. Chandrasekhar will present. Dr. Chandrasekhar is a consultant neurosurgeon at KIMS Hospital, Hyderabad, India. Dr. Chandrasekhar, can you please present?
Sir, am I audible?
Yes, yes.
Yeah. So good evening, sir. On the outset, I would thank Professor Manas Panigrahi and the Neuroendoscopy Society of India and WFMS for giving an opportunity to present this case. Today we'll be presenting regarding ventricular catheter delivery device. What we analyzed and we found that it's useful. So the ventral catheter placement is very important, and to avoid shunt dysfunction, the correct placement of ventricular catheter is important. So if you see these images, this as normally ventricular catheter placement is a blind procedure, so we don't know where exactly it goes. So this is a right placement of the ventricular catheter. There's some abnormal placement also can be seen in this image. And in this case of multiloculated hydrocephalus, where there are multiple cysts, to place a ventricular catheter after septostomy, it may be very difficult. So, seeing these complicated cases, we came to a technique which will be demonstrated in the coming slides. So, placing a ventricular catheter during VP shunt is a blind procedure and results in frequent ventricular catheter dysfunction. Some shunt obstruction is approximately 17%, with ventricular catheter blockage being which is the most common. To improve the placement of ventricular catheter, various techniques developed, including navigation, stereotaxy, ventriculoscope guided shunt tube placement. These techniques have its own limitation due to excess time consumption and complexity. So optimal placement of ventricular catheter is very important for outcome of shunt surgery. So what is the normal cause of obstruction? Brain parenchyma, septa, tangled in choroid plexus, clogging of ventricular catheter due to brain matter and other debris. which are the common reasons for complete or partial dysfunction. And to resolve these dysfunctions, multiple techniques have evolved. So one of the technique or one of the instrument which is very much used is a shuntoscope. It is a instrument which can go into the ventricular catheter, and then under direct vision we can place ventricular catheter. So some studies we have seen the literature regarding the use of shuntoscope and a freehand technique, which I will be demonstrating in the coming slides. So this is a study where shuntoscope guided versus freehand technique, where they compared between the both, and they felt that shuntoscope is better in correct placement of ventricular catheter. These are the different indications. And what are the then in this study, the shuntoscope has significant p-value, and it has got advantages in correct placement of ventricular catheter. So they have concluded in this study that ventricular catheter placement using a shuntoscope guided technique is a safe and effective procedure which enabled a significantly higher success rate and lower revision rate. These findings they require broader research. So this study is in favor of shuntoscope. So there is one more study which has come in child nerve system, which was saying that for all cases shuntoscope is not required, only for complex cases. And they feel in this paper that the routine endoscopic assisted ventricular catheter it doesn't reduce proximal dysfunction, and the cost of such hardware precludes its wide application. So it is not, they're telling that it's not for every case. So we have a few cases where we would like the opinion of the experts, how they do this in these complex cases, how thalamic lesion with ventriculomegaly. In this case, we need to do a septostomy and placement of ventricular catheter for having a better outcome. So I would like to ask the experts to tell us if they are using shuntoscope, or if they're not using, how are they able to place a ventricular catheter in complex cases.
Chandrasekhar, please finish because we're running short of time. After your presentation, we'll ask opinion.
Okay, sir. Shall I continue my video, sir?
Yeah. Yes.
Okay.
Continue your presentation. Not.
My presentation is complete, sir. I want to show the video of what we are doing.
Yeah, I saw the video. Okay. You're opening the video.
I'm opening the video. So is the video visible?
Yes.
So this is how we prepare the ventricular catheter. We make extra holes. So I will be demonstrating a live two cases where this is entry into the ventricle. Foramen Monroe. We are doing a septostomy. Septostomy is done. And now we come out after septostomy and then go in with our ventricular catheter with the Fogarty. Under direct vision, the shunt tube is under vision, and with the help of Fogarty, we can place the extra holes when we see, so that both ventricles are drained. And we're coming out, and we'll be holding the ventricular catheter with the fingers and then removing the scope. So it's the second case where a thalamic lesion. we'll be doing septostomy. Septostomy is being performed. And with laser, that opening is been increased. This is a thalamic. With laser, we will open the thalamic lesion and take a biopsy now. Biopsy has been taken. We use thulium laser for hemostasis in these cases. Hemostasis is secured with the inferior bulb of the Fogarty. Once the hemostasis is secured, we check the hemostasis secured, and now we come out and again now go in to place the Fogarty guided undervision ventricular catheter to the opposite ventricle. Undervision, and we hold the ventricular catheter and then we come out. So my presentation is completed.
Yeah, thank you, Dr. Chandrasekhar. I'll request all the panelists to the comments or Dev Pujari, Borbas, Dr.
Yeah, Dr. Manas, I think. Yeah, Dr.
Manas.
Please.
I think the shuntoscope is an excellent idea. Those who do not use it, or till we recently got the shuntoscope in our theater, what we have been doing is we have been using AM navigation, and to the sort of you usually get a malleable small probe along with the catheter, which we have been using that to place the catheter in right place, and then visualize it with the endoscope. So that is a alternative which can be used, but shuntoscope is a definitely very good idea if you are in doubt or if you want to be absolutely certain in a complex case.
Yeah, Manas is a nice technique. What I do is, after doing a multilocular hydrocephalus, once we complete the penetrations with endoscope, I just take a 0-degree inspection scope, without any other devices which is required channels. I straight pass the endoscope to the best extent distal cavity as possible. And then I have a long stillet. I take the stillet into the catheter, ventricular catheter. Take that along by the side of the endoscope to the maximum place till you see the tip, and then withdraw the scope and gently release the stillet outside. So that way, I never lost the catheter inside the cavities and could reach the maximum accessibility. Also, of course, making multiple holes is a must for all the things.
Chandrasekhar, please unshare your screen. Dr. Sankla, please.
Yeah, but did you do you have any post-op CT or something to really show us, where exactly the catheter goes and how far it goes inside and all that? I'm sure you must have connected on those patients.
Yeah, I mean, I cannot show you now, but we have post-op CTs.
Yeah.
Here,
so how do you decide the direction as well as the length of the catheter which goes in the opposite ventricle?
Means from the pre-op CT we calculate what is the if it's a normal shunt, we calculate beyond the foramen membrane. Here we calculate beyond the septum what is the length required, and here we are putting under direct vision. So as Dr. we don't use a stethoscope. As Dr. Venkatramana explained that he uses a long stillet and he places it parallel to the shunt, pushes it and keeps it. So here we are going through the working channel of the shunt. So we were just fixing in front of the Fogarty catheter, and it doesn't slip out. So the Fogarty catheter goes through the working channel of the working shunt of the endoscope. So then we place it wherever we want under direct vision. So it's not that we have to confirm.
Right.
As I showed in the video, it is through the working channel.
Okay.
It's
And
not through the side of the withdrawal, because the catheter is long. So when we take out the shunt tube, the junction of the Fogarty and the shunt tube is there outside only. So there you're detached with the finger, because all the time ventricular catheter are longer. So when we to withdraw the endoscope, we see we detach it with manually from the Fogarty from the ventricular catheter.
Perfect. Got it. Thank you.
Yeah. Okay.
Where do you?
Like it's a cheaper alternative for shuntoscope, because shuntoscope. Yeah.
It happens only if the other side of the shunt is in line of your scope. What happens in multiloculated hydrocephalus where we want to place the catheter slightly, which is not in straight line?
Yes. See, this is, it's like whatever you can do with a like flexible, or you can do with your Fogarty catheter, you can do it here. Okay, so because when you put the shunt, you means you know where exactly you're putting it. No, means it is better than doing it blindly.
Yeah.
So it is, and if you don't have a shuntoscope, also you can do it only in a straight trajectory, and then it is expensive, and it's a cost-effective alternative to shuntoscope. That is what is the aim of presentation.
The goal is to minimize the number of catheters in the ventricle. So you try to get the straight line access. That's something which you need to calculate on the scans, and that try to decide and go through, which can go through maximum number of loculi. It is something beyond the reach of that, then you need to put a second catheter if it is inevitable. Otherwise, if you can access with one single access maximum loculi, that is the best way to do that.
Manas, can I ask you, Manas, something? Where do you place your burr hole? I want to ask something very basic.
It depends. It depends on where we are planning to do the. From the pre-op scan, you have to decide where you want the septostomy or multilocate. So that, depending on that, you have to make a trajectory, a single line where the burr hole will come to, and make the burr hole there.
Yeah. So but in the second case with thalamic tumor, where did you place your burr hole? We have two burr holes. One burr hole in the parietal for taking biopsy from the thalamus, because we enter the pulvina, and one burr hole was separately in front for the septostomy and all those. It's not the same. Two burr holes we make. So you had two burr holes. So through one burr hole you introduce your instrument for the biopsy, and the other one was to put your catheter. Is that right?
Right. Means because it's a thalamic tumor, our plan was to do a septostomy, biopsy, and a single shunt instead of doing a bilateral shunt.
Yes. Yeah. So in this case, if you just put a frontal burr hole, I think you can do both the things in one through one big burr hole. Is that right?
Yeah. It is possible. It depends on the size of the thalamic tumor. If it's bigger, one can do with only a frontal burr hole. But if it's a smaller tumor, then it becomes a problem.
Because this was quite a big one. I mean, I thought that single burr hole should have done the trick, but you.
Yeah, but we have been practicing doing biopsies from the parietal burr hole for thalamic tumors.
Right.
And septostomy from the parietal burr hole becomes a little difficult.
Mm-hmm. Right. I had worked in Sheffield where they do all the shunts through frontal burr holes.
Yes.
They never use parieto-occipital burr holes. So the shunts, all shunts.
Yes.
I mean, I'm not talking of septostomy or any procedure, ventricular procedure, but all shunts through frontal burr holes, where they say that they claim, there's nothing published, but they claim that the shunt blockage because of coraplex and other things are much less as per their understanding. So that was something interesting which I had the experience to see and do myself, and quite a huge number of patients. So all shunts through frontal burr holes, nothing through parieto-occipital burr holes.
Yeah. So here, like if you do use a parietal parallel, also you can try to place the shunt tip beyond the foramen Monroe so that there is no choroid plexus.
Yeah.
Can you ask for any other questions that I can ask Dr. Tyagi to share his screen? I have requested Dr. Tyagi, can you please share your screen? Yeah, Dr. Dwaraka also to be here. He's the head of the Department of Neurosurgery at NIMHANS, Bangalore. So if there are no other questions, we'll go to Dr. Tyagi, and he will be presenting neuroendoscopic management of pediatric complex hydrocephalus, and he will show us a series of complex cases.
Yes, good evening, sir. Thank you very much for providing me this opportunity. Good evening, everyone. So today I'll be discussing on neuroendoscopic management of pediatric complex hydrocephalus. So hydrocephalus, as we all know, I quickly rush to the introduction. It's been described since the early ages, and it is one of the most common surgery done initially by the trainee neurosurgeons, and you see this throughout our careers. Pediatric ventricular shunts, they add a lot of clinical and financial morbidity to the patients. And in a study, the patients were followed over 20 years, that every person underwent almost up to 2.66 revisions over 20 years. Post-hemorrhagic, post-meningitic, congenital, and communicating hydrocephalus cases are the most difficult to treat. Coming to complex hydrocephalus, this results from multiple intraventricular septations and multi-causal etiology. Spinato et al. Classified these into 5 predominant varieties, where hydrocephalus with multiple interventricular septation, isolated lateral ventricles, entrapped temporal horn, isolated fourth ventricle, and expanding septum cavum. Multiple compartment shunting increases the risk of multiple implanted shunt and high rates of revision. So endoscopy provides a minimal invasive, more physiological approach of communicating all these isolated CSF spaces. Another another cause of a complex hydrocephalus, pediatric intraventricular cyst. And non-neoplastic etiologies include post-meningitic, multiseptate arachnoid cyst, less commonly ependymal cyst, and infectious like neurocysticercosis. So neuroendoscopic cyst fenestration can improve the hydrocephalus rate in more than 75% of the patient. Need for shunt insertion can be avoided in 12.5% patients, and endoscopy can reduce the revision rate from 2.9 per year to less than 0.5 per year. So I present an interesting case here. It's a 4-year-old male firstborn child with global developmental delay, and he had increasing head size from the age of 1 year and had multisemiology seizure for last 1 year when he presented to us. There was regression of motor milestones for last 3 months, and at the birth history, he had a full-term breech, cesarean, low birth weight, and birth asphyxia and neonatal ICU admission for 11 days. On examination, he had a large head, all fontanelles were closed. There was poor neck holding of the child, and his developmental age was 10 to 12 months. There was no obvious motor or sensory deficit as such, and his vision was grossly preserved. This is the pre-op MRI of the patient. On CIS 3D image, we can see that there are grossly dilated fourth ventricle as well as bilateral lateral ventricles. The mantle is poorly formed, and there are these 2 well-defined cystic lesions within the brain, within the ventricles on both sides, on the both lateral ventricles. The fourth ventricle is enlarged, and the outlets appear to be blocked, with causing a trapping. And this on the sagittal images, we can see that the third ventricle is also herniating into the suprasellar cistern and the sella. So the management challenges were, this is a arrested hydrocephalus. There is decreased mental. The pliability of the ventricles decreases in these patients. Then there is presence of aqueductal stenosis. There is intraventricular septations and the 2 distinct cysts, and there is a trapped fourth ventricle. So the management strategy was, we do an endoscopic cyst fenestration and septostomy, and with or without septostomy if required. Then we do a third ventriculostomy, which will open the alternate pathway in case the cyst recurs and block the foramen Monroe, and follow the child in the child guidance multi-departmental rehab of the child, and keep a close neurological and radiological follow-up for trapped fourth ventricle, whether it required an endoscopic aqueductoplasty or megendiplasty at a later age. So we did a pre-coronal burr on the right side, and as we enter the ventricle, here we can see this well-defined cyst wall, which was tense and pulsating with CSF. We performed by coagulation. We fenestrated the cyst wall, and when you go inside, you can see the choroid plexus is completely within this cyst, the larger cyst on the right side. We dilated the opening with a Fogarty's catheter, and you can see the cyst wall has completely collapsed. Now you can see the foramen of Monro on the right side, and the septum here is fenestrated, and this is the cyst on the opposite side, which we have gone through the septum, which was deficient in multiple places. And this cyst wall was also cut, and a part of the wall we had taken for biopsy. As the cyst on the opposite side is also decompressed, we come out and see through the septum. This is the cyst on the right side, which was completely collapsed. Then here the deficient septum and lateral ventricles of both sides are seen. We coagulate and devascularize this cyst to reduce the size of the cyst. And now we can see the foramen Monro clearly. Here is the coagulation and fulguration of the cyst wall to shrink it and reduce the chance of recurrence. This is through the foramen of Monro. We can see the third ventricle. We go there and perform an ETV just behind dorsum sella. And this third ventriculostomy is expanded. And this is the end of the procedure. So post-procedure, after 6 months, this is the follow-up MRI of the patient. You can see the fourth ventricle has increased in size. And the ventricles are the same size, but the cyst wall has collapsed. The outcome at 6 months follow-up, there was neck holding has improved, and the patient was able to stand and walk with support. The head circumference has remained stable and under physical therapy and pediatrician care. These are the comparison of a pre and post on the follow-up MRIs. On both the upper images are pre-op and lower are the post-op. We see the cyst wall has collapsed. And on the right downside image, we can see this endoscopic, third ventriculostomy that we had done is patent. The fourth ventricular size is almost the same, but the patient was not symptomatic for it, so we plan to keep him for follow-up. So to conclude, neuroendoscopy for complex hydrocephalus, minimally invasive, avoids multiple foreign body implants and shunts and in multiple compartments, so less causes of malfunction. And it is more physiological compared to diverting CSF outside the brain. For complex pediatric hydrocephalus, multi-departmental team effort is required for good outcomes. So these were the references, and hope everybody have a Merry Christmas and a Happy New Year.
Thank you, Dr. Tyagi, for the beautiful images and beautiful way of managing and the videos. And now the case is open for discussion. Professor Dev Pujari, Professor Venkat Ramana, Professor Sankla, Dr. Pathak, and Professor Borba.
What's the histology of the cyst wall?
Sir, we believe this is patient must have had this is probably post meningitic post.
You took a biopsy. You said you took a biopsy also.
Yeah, that was arachnoid cyst. It that was they have given arachnoid ependymal. They have given a mixed. We believe it was arachnoid pattern only.
Right.
Can I ask something to Dr. Tyagi?
Yes, sir.
Yeah, please.
Very good presentation, Dr. Tyagi. Wonderful, actually. My question is that when you are doing the septostomy and going to the opposite side to make a fenestration in the opposite sided cyst, where do you what area you choose to the septostomy to be able to do the fenestration? And if there are multiple cysts on the opposite side, then the septostomy's location site is very, very important. How do you decide that? Do you take a navigation and do this or on the pre-operative scan?
Actually, in this case, the septum was deficient. So there already it was fenestrated in multiple places. And we did not actually had to do septostomy for this patient. But if we have to do, so we will do it behind the anterior septal vein. And from the same burr hole, this can be done. And we have to do it around 2 centimeter above the foramen of Monro and behind the septal vein. And
yeah.
But in the current case, it was not required because the septum was deficient at multiple places. Even in the scans, we were able to see, and intraop also, the septum was deficient.
So this is the standard, location for the septostomy described and practice. What I'm saying is that if the cysts are not in the same location, cysts are little anterior or posterior or more lateral, then you have to alter.
Yes,
then
sir.
you have to alter. Yeah.
And yes,
sir, then I think, see, the ideal way to do a cystostomy is to puncture the septum where it is bulging. And that's the easiest landmark to be seen. But the problem, again, you realize is that once you enter the ventricle and the pressure is released, there will always be a bulge from the opposite side. So by the rule of the thumb, you can use that to penetrate into the opposite side cyst and do the cystoventriculostomy.
Right, yeah. And the other thing is, when you are in the ventricle, do you do the ETV first, or you go and do the septostomy and do the fenestration in the contralateral side?
First, the ETV is done. But in this case, we had to do the fenestration because the cyst was in the way to the third ventricle. So, theoretically, the ETV has to be done first always. Because if there is any bleeding, the ETV can get obscured, the path can get obscured. So I do the ETV first, then follow it up with the cystostomy, unless the cyst is in the way, like in this case.
Good case. I think, it depends on case to case, but yes, general principles which you have described are really very good, understandable. Thanks, Dwarka, for your inputs.
Yeah, thank you, Dr. Tyagi, and thank you, Dr. Dwaraka, for participating in the last minute. Can you please unshare your screen? And I request Dr. Anshu, is a consultant neurosurgeon at Global Hospital, Mumbai. Yes.
Manas, can I say a few words about Dr. Varade? Dr. Varade is a new young neurosurgeon who has joined our team at Global Hospital. And this case is a young child who had multiple shunt revisions and many problems. So the idea of presenting this case is that sometimes you don't find the foramen Monro's location as you have expected, even if you have done an extensive analysis or evaluation on the preoperative scans. So then you are worried, putting your endoscope through the foramen to be able to do the ETV. So when you come across this situation, what are our options and how you manage this thing? Dr. Varade, please share your screen.
Good evening, everybody. So I'm presenting a case of a difficult ETV. So a 3-month-old girl presented to us with large head, which was progressively enlarging. She was lethargic on presentation, had refusal to feed, had multiple episodes of vomiting, had excessive cry. On examinations, her anterior frontal was tense. She had upward gaze palsy. Hello. Her CT scan showed enlarged dilated ventricles with periventricular ooze, with effacement of sulci gyri. So she underwent right VP shunt, following which her symptoms improved. So she underwent multiple shunt revisions over a period of 4 years elsewhere. Shunt was put on right side, then left side, reservoir was put. So for 4 years, these things kept on happening. Then finally at 4 years of age, she became relatively all right. Then she was asymptomatic for 2 years. And then at 6 years of age, she again presented to us with enlarged dilated ventricles with periventricular ooze and progressively worsening of headache and vomitings with the drowsiness over 2 days. So our plan was to do an ETV and removal of shunt without putting any reservoir. So we did a standard precoronal right-sided burr hole away from the midline in the mid-pupillary line. So this is the video of the procedure. So the endoscope was introduced into the right lateral ventricle, and the choroid plexus was traced anteriorly to the foramen Monro. But what we see here is that through the foramen of Monro, we could just see the aqueduct, but we could not see the anterior third ventricular floor structures. So we tried to manipulate the scope, but the anterior column of fornix was coming in the way. We tried manipulating it further, but we couldn't get through. So the options available to us were removing the sheath and just put the scope and then try the ETV. Use a 30-degree scope. Use of flexible scope. Do a foraminoplasty and then proceed with ETV, which was not feasible as it may cause damage to fornicial pillars. Aqueductoplasty again was not feasible as it causes damage to periaqueductal gray matter. Another option was to put in a new burr posterior to the previous burr site so that we get a direct trajectory to the anterior third ventricular floor, or place a new burr on the left side and do a fresh left-sided approach and do an ETV, or do a shunt revision if nothing works. So what we did was we gently withdrew the scope and saw that there was a large spontaneous septostomy through which the contralateral choroid plexus was seen. So we traced the contralateral choroid plexus to the foramen Monro on the other side, and the third ventricular floor was seen relatively well as compared to the other side, to the normal right side. So we tried putting a blunt cautery probe and did ventriculostomy. We inserted Fogarty's French catheter number 4 to dilate the opening. And as soon as the Fogarty's was removed, we could see the flapping of membranes nicely. The basilar artery and its perforators were very well seen through the ventriculostomy opening. So post-operatively, she improved. Her headache, vomiting subsided, and she was discharged without any focal neurological deficits. This is her post-operative scan, which showed resolution of hydrocephalus. So when we reviewed the literature, difficult ETV has most of the times been described in context of difficulties attributed to the third ventricular floor, like narrow spaces between clivus and basilar artery, large interthalamic masses, thick Lilliquist membrane, high basilar artery location, opaque floor, narrow tubercinarium, hollow or steep third ventricular floor, vascular third ventricular floor, adhesions between mammillary bodies or adhesion between interhypothalamic masses. But very little data has been described in literature, which shows basically very little data has been described in relation of foramen Monro to ETV, where the anatomy of foramen Monro has not been studied properly. So this is the recent article which was published in ACTA in 2019, which used virtual reality imaging, in which DICOM data of submillimeter slices of CT and MRI are used to locate the foramen Monro and its anatomy with pinpoint accuracy. So this virtual reality imaging can be used preoperatively to study the anatomy of foramen Monro and its orientation. So concluding, imaging should be studied thoroughly preoperatively. all the normal anatomical landmarks should be used, which are standard, like pre-coronal burr-hole in the mute pupillary line. And we should be aware of alternative strategies as described. At T2 weighted MRIs, mid-sagittal imaging is kind of mandatory to look for the third ventricular floor structures, and a coronal MRI T2 at the level of foramen Monro to look for the anatomy and orientation of size of the foramen Monro. In cases of large septostomy and favorable anatomy, where the damage to the fornix and the surrounding structures cannot be done, then only this contralateral approach can be attempted. So, thank you.
Yeah, thank you, Dr. Anshu. And I request the panelists to give any comments.
Thank you.
Please,
We actually described a similar case in our secondary third ventriculostomy series in a spina bifida case. And I think that spina bifida is one of the most important causes where the foramen of Monro does not somehow significantly dilate. And because of large interthalamic connection, you don't get a good entry. So this is a very nice way of doing it. And we also found that this is probably the best way rather than trying all other alternatives which were mentioned.
Dr. Devpika, do you do a new fresh septostomy to be able to go the contralateral side, or you look for the...
in fact, I was prepared to do that, but I also got a spontaneous good septostomy. Did not have to do that.
Right, yeah.
Dr. Shankla,
yeah.
What would have been your approach if the spontaneous septostomy was not there?
Probably I would have backed out that time. But now, after this case, and there's one more case where we found something similar to that, I would be now, next time onwards, would be more positive about doing a septostomy and going to the contralateral side. If I can go there safely, I will do that.
Yeah, I think so. I would done a septostomy. So sometimes you get a better access on the opposite side.
Yeah.
The another thing, if there is a small, enlargement of the cavum, only confining to the anterior, like cavum, septum pellucidum, or a small cyst in the septum, sometimes obscures like this. You only see the posterior aspect of the third ventricle and not the anterior. So that is why septostomy and going from the opposite foramen of Monro sometimes gives a better access.
Absolutely.
I think I would agree. Septostomy definitely can help, and I have done 2 situations where I have done it septostomy. That's already described in the literature also, but that procedure. The other thing, of course, I have not seen anybody doing it, but there's description of monroplasty. There are articles on that, and I've never ventured to do that. So that something should be kept in mind also.
Yeah.
Here is a use of a flexible endoscope. Actually, I had presented some of these cases of abnormally placed foramen of Monro.
Absolutely.
Yeah.
So today's discussion, number of indications of flexible are coming out.
But everybody doesn't have flexible endoscope. So what, like you?
Once you use it, you'll have it.
Yeah.
We have Professor Dakuna with us. Arthur, do you have to? Can you make a comment on this problem? Arthur, are you there?
Yes. Yes, I am. I think it does. For us, it's not so difficult because we usually use the neuronavigation. Yeah, and then we can very easy to locate the flow of the third ventricle. So we plan our trajectory before. It's not, with neuronavigation, I think it's very easy. Yes.
Yeah. Before doing foraminoplasty, one of the small tricks is to nicely coagulate the choroid plexus completely there.
Yes.
So it gives more access for the scope to go there.
Absolutely.
And you can get a smaller scope and go inside.
In fact, that is the first step of foraminoplasty.
I think so.
Yes.
Yeah, I'll request, because we're running short of time and Professor Sufiano is already here. I request Dr. Subodh to please introduce Dr. Sufiano, and I'll request the speakers to answer the questions. There is something more in the chat box. Dr. Sankla, please answer. There's a chat box question. Dr. Subodh, can you please introduce?
Yeah, a very good evening, everyone. I would like to, last but not the least, welcome Professor Albert Sufianov. He is the Chief Physician, Medical Director of Federal Center of Neurosurgery, Chairman of Department of Neurosurgery at the first Moscow State Medical University. He has a keen interest in neuroendoscopy, and he also has a number of presentations, memberships, affiliations, and because the combination of interest in pediatric neurosurgery and neuroendoscopy, we would like to hear from him about an optimized technique of endoscopic surgery in children with occlusive hydrocephalus. Welcome, Dr. Sufiano. Over to you, please.
Okay, good evening for everybody. I am Dr. Sufiano from Tyumen. I present experience of the Federal Center of Neurosurgery team. And first, I want to say thank you very much for the organizers of this meeting, interesting me for inviting me and give me possibility of sharing our experience. In this presentation, I want to speak about our experience of the semi-rigid needle neuroendoscope in using of the treatment of the hydrocephalus and the complications of hydrocephalus. I am from Tyumen, it's a city where we create the Federal Center of Neurosurgery. And now we know what in neurosurgery, most important tendency now is the evolution to the malinvasive neurosurgery. So we have also experience from the standard craniotomy, just a keyhole approach, and now from the beginning we start with endoscopic surgery, and now I want to present our experience with the really minimally needle endoscope. I call this is a stitchless neuroendoscopy. This is, but our perspective is the neurosurgery without the contact. Neurosurgery. This tendency need a lot of improvement in the manual experience of surgical and the technical equipment in neurosurgery. You see in this slide, it's easy to see. And for this kind of surgery, we have a lot of knowledge in endoscopy, and we have a cadaver lab, and we receive a lot of knowledge in this cadaver lab. So especially in brain ventricle tumor, because I very limited in time, so I not explain all about the anatomy, just only to show our experiments, our main landmark. For example, we see the anterior wall of the third ventricle, the landmark for lamina terminalis and posterior and so on. Yeah.
I think the slides are not
again. Now again about the neuroendoscopic equipment.
Okay. Hello, Professor. Can you in the presentation? I think your
slides are not moving forward.
Now it's okay?
Yeah.
Now it's okay.
It's okay.
Okay. The main for this kind of surgery, especially with needle endoscopy, you must very well knowledge about the anatomy and landmarks. Especially one of the main is the interpeduncular system. You see the slide about the main landmark, for example, and also one of the most important is the neuroendoscopic equipment. We have a standard endoscopic towel, and most interesting is our endoscope. What we use, this is really a semi-rigid needle endoscope. You see in the slide, the outer diameter is less than 2 millimeters with working canal. You see on this slide. Compared to the LOTA, for example, this is our, this is LOTA. So twice our is less. You see the common view of this endoscope. This is this endoscope yourselves, and this is a working sheet for this endoscope with the working canal. This endoscope have a very unique possibilities. For example, it's possible navigated this endoscope. You see the navigated endoscope with the sheet. And we see our operation room with equipment. For example, this is the ICT operation room with CT intraoperatively. In difficult case, we use also intraoperative CT also, because most important in neuroendoscopy is the orientation. You see the step by step. Another very important tool is compare other endoscope. Standard endoscope is the possibility of use this endoscope with the real-time ultrasound navigation. You see the navigation probe, and you see the device for this navigation probe, and you see the endoscopic. Our endoscope we use with this real-time ultrasound. Sometimes it's much better when you use the neuro navigation, because we know hydrocephalus is a very great shift syndrome. So maybe neuronavigation most cases not very precise. So only ultrasound navigation is a real decision of some difficult problem in this hydrocephalus. This is example how we introduce endoscope in the target by use ultrasound. You see the trajectory, and you see put by the trajectory endoscope just precisely in the even very narrow ventricle. For example, you see the picture from the endoscope like this, and you see how we check potential of the stoma by put the water inside the endoscope. Fixation is typical for the child is the DORA system, most useful in our experience. And this is just our entry point, just only needle, no wound, no big wound, no bar hole. We use a lot of approach. You see the anterior transventricular approach, middle transventricular approach, posterior transventricular approach. It's possible by using the scope, and this is the most possible indication for this kind of surgery if using our semi-rigid needle endoscope. It's a lot of indication. You see possibility of endoscopy for hydrocephalus. You see, you see the septum pellucid infiltration, foraminoplasty, ventriculostomy, aqueductoplasty, and so on. Pineal cyst, arachnoid cyst, supracellular, and so on, the Sylvian arachnoid cyst, and so on. Even epilepsy now is possible to treatment by using our endoscope. So I start from endoscopic procedures, the hydrocephalus treatment. You see the typical ETV by using our endoscope. You see the complete set for this kind of ETV. You see the very small diameter of the endoscope. So it's possible to make ETV like this and just go inside of the interpedicular very deeply, not like compare the standard endoscope. So this is one of the most advantages of this kind of endoscopy. You see, we go inside, dilate the stoma by the Fogarty catheter, and we go inside. And we see a lot of problem inside of the interpedicular system, but by this very thin semi-endoscope, it's possible to go very deep, very deep. Not possible by standard endoscope like this. So why you must have much better result when compared the standard endoscope in this kind of posture for TV, for example. You see the example, the case, very difficult case, post-hemorrhagic obstructive hydrocephalus. And this is the ETV. We go inside of the ventricle, you see a lot of post-hemorrhagic events. Very difficult for orientation because no good landmark. But now we try to find the optimal target for the fenestration. We use the deck forceps. And now when we dilated the stone by the Fogarty catheter, and most important, this kind of hydrocephalus, possibility of the revision of the interpeduncular cistern. We go inside and see a lot of problem inside, and we dilated the interpeduncular cistern by the possibility of this kind of endoscopy. You see? The stoma. And we go inside again, check possibility. Now we open the interpeduncular system under the visual control. Not possible like this with the standard endoscope. Only this kind of endoscope is possible like this. You see, we now are very deep inside of the interpeduncular system, and open the system. Post-op, very good result, very good flow through the stomach. Also, some combination is possible, like ETV, covidoplasty, and cyst fenestration. You see the big cyst inside of the aqueduct, some membrane. So at first we make the aqueductoplasty, delay the aqueductoplasty. Now we go to the cyst and open the cyst also. Now we open the cyst fenestration and then ETV. After treatment. Also possible ETV plus endoscopic septostomy and catheter removal. Anterior process. Now we see inside. This is a view from the inside of the vertical catheter. And when we remove the catheter and go inside the canal after the catheter, inside of the lateral ventricle. We now in lateral ventricle, very precisely, without any limit, without any problem. We just use all canal from the ventricle catheter. Now we go, this is the foramen Monroe, we go inside of the third ventricle. You see, very narrow, very narrow. It's just minimally, very minimal exercise. It's not possible to do ETV by standard endoscope. Only this kind of endoscope is possible to use. You see the mammillary body. Now we make ETV by the deck forceps. This is a very small size of the third ventricle, very small. It's only semi-rigid needle endoscope is possible using this kind of surgery. Now ETV done. Go deep on the ETV in the interpeduncular cistern. We see open the cistern more and more for safe circulation. You see, we now open completely interpeduncular cistern. Again, only this kind of endoscope is possible to use in this situation. No standard endoscope, only this. Very narrow third ventricle, you see. ETV is done. And now we also create the fenestration of the septostoma. Also very easy without any technical difficulties. This is post-op. This is also a very difficult case about the slit ventricle syndrome. Yes, we know all neurosurgeons that slit ventricles sometimes very difficult problem. So again, we check the ventricular catheter from inside, coagulate, and just to prevent the bleeding. When remove the catheter and when go to the lateral ventricle through the old ventricular catheter canal without any problem. We just go inside of the lateral ventricle. And we replace ventricular catheter also. Just to open the lateral ventricle by the increasing the pressure of the in the place without the holy plexus. And
I think we have problem with presentation, huh?
Yeah, it stopped, I think. Dr. Sufiano, are you online?
Last time.
I have got disconnected.
Lost.
Frozen in the Russian winter.
Yeah.
Cold line.
Dr. Borba is there. Professor Borba.
Can have some panel discussion in the meanwhile.
Yeah, he's come back.
Is it coming back? Is come back already or no?
Sufiano has come back. We cannot hear you. Can you please unmute yourself? Yeah.
this is the placement of the ventricular catheter through the septum under visual control. Arachnoid cyst treatment, also another good possibility for this kind of endoscope. You see the cilium fission, big one, and you see the how we treat the arachnoid cyst. Good landmark. You see the chiasm, optic nerves, carotid artery bifurcation. We see the third nerve, and between carotid artery and third nerve, we create now a fenestration. We also you see the deck forceps, creates the fenestration, and again for this kind of endoscope, it's possible to go very deep inside of the interpedicular system, not like the standard endoscope. Again, very deep. We delay the stoma by the forward catheter, as usual. And you see now we completely open the interpendicular system. After operation, cyst size decrease. Pineal cyst, also very interesting possibility. You see the big cyst of the pineal region. In this case, we use ultrasound navigation. You see the directory, very narrow the ventricle, but no problem put inside because it has real-time ultrasound navigation. Now we go inside the third ventricle, you see the cyst. Open the cyst by deck. We are inside of the cyst. And after, we create the big fenestration. And then we open also the aqueduct. You see the aqueduct, aqueductoplasty. Result after operation. Subdural hematoma also possible, step by step. Epilepsy, another interesting indication for this kind of surgery by this endoscope. For example, you see the anterior commissure and possible to make anterior commissurotomy. Also by ultrasound navigation, you see the endoscope, go inside of the lateral ventricle, very narrow ventricle, but no any problem. Go step by step, and we cut anterior commissure inside of the third ventricle. Gemonergy also possible. Intracranial aneurysm also possible just for assistance. Step by step. Even in neuromodulation, it's very useful because it's possible to put electrode very precisely in the target. And our top is intrauterine neurosurgery. We performed a fully endoscopic intrauterine ventricular cysterectomy. This is our patient after 2 years, and this is our stoma after 3 years of surgery, after delivery of the baby. Thank you very much for your attention.
Thank you, Professor Sufianov, and for actually means the presenting on the miniature endoscope and its uses. I had listened to your presentation. That's why I invited you for this, so that everybody also has the experience of your technique, especially in small foramens. It is very useful. With this, I like to open the lecture for discussion. So Dev Pujari wanted to ask something.
I have a question.
Yes.
Yes, I'm really curious about something. You have only 2 channels. I talk about intraventricular endoscopy, yes, and you have only 2 channels. One for optic device and another one for instruments. What about the irrigation in and out? What happening if you have bleeding?
No, we have irrigation also. Just we have also third canal also for irrigation. We sure. We have a lot of different sheets. It depends from the function what you want. If you want to do some surgical manipulation with the operation sheet, with the locking canal and the one canal for irrigation. Another canal also with irrigation just for shuntoscopy, for example. See, this is a working canal. This is for irrigation, just in certain conditions. It's enough. It's enough. This is just for put the stand, for example, like it's also with irrigation. Just for just only for endoscopy, not for manipulation. You see like this. But also we have irrigation canal.
Can I ask something?
Yeah, please.
The instruments that you use are, I would suppose, are different from the ones that we use in the standard endoscope. Is that right?
No, it's some instruments is possible, but mainly is produced by Storz company just for this kind of endoscopy.
Right. Okay. Now, when you are operating in tough structures, like tough arachnoid membrane and things like that, how good are these delicate instruments? There's arachnoid adhesions and sometimes they're really very tough, because you showed very beautiful dissection through the arachnoid planes.
Okay. If we have very delicate arachnoid membrane, we use standard instrument. But if you have some very strong membrane, for example, I use because I'm very limited in this presentation. We use laser for this kind of surgery.
Right.
It's possible to use some from laser some. Okay, 500 micron, 500 micron is possible to use from the laser.
Right.
I use thulium laser.
Thulium laser.
Especially for the epilepsy surgery, tumor surgery, because I'm very limited. But this endoscope is a lot of possibility and other, not only hydrocephalus.
Right. Thank you.
Yeah, as we are already running short of 10 minutes over from the time, before we conclude, I'll request Professor Boba to give a concluding remark on the collaboration of WFNS Education Committee with Endoscopy Society. Professor Sufiano, can you please unshare your screen?
Hello, everyone. I was here the whole morning watching wonderful presentations in very difficult case. Do you know, you have a lot of webinars about complex skull-based tumor, complex vascular tumor. But day by day, you have a lot of hydrocephalus. You have a lot of complex cases that are from the whole world in every part of the world. What our education committee want to do is to study this from the basic to the most complex. Hydrocephalus you have in every hospital in the world. Every neurosurgeon in the world treats hydrocephalus. But probably the great majority of neurosurgeons in the world don't know how to treat complex hydrocephalus. And this patient is in your hospital. You cannot move to a big center sometimes. You have to treat, you have to do. I'd like to name, on behalf of our committee, and Professor Manas is a member, Professor Sushanov is a member, and many people from around the world, to thank you for this webinar and say that this is the way that we need to teach the people, from the simple to the most complex way to treat several pathologies in neurosurgery. For the end, to make a point to say about where the presentation of Professor Sufyanov. I go to Tumin since 2014. It's amazing what I see, what I saw every day where Professor Sufyanov and his team are doing with endoscopy, with the young children, the adults. It's unbelievable the technology that he has, the facility that he has. And these facilities, Professor Sufyanov, always open to the whole world. Into this area around the Tumin, I think you have the opportunity, this large and very well equipped federal center, to open to all young neurosurgeons medical students that want to be dedicated to neurosurgery. And for us, a senior neurosurgeon, to learn and improve neurosurgery in very friendly environment. See, I think we need to be together, leave the world different to us, but the neurosurgical world has to be together to learn to everybody. Thank you, Professor Manas. Thank you, Professor Artur Cunha from Brazil. I know that we are in vacation now, but thank you very, very much for the opportunity to be here in the morning. And congratulations, Dr. Sufyanov, for the professor in Kyrgyzstan. Yes, today professor of Kyrgyzstan now. Okay. Thank you.
Professor Bobas, before I request Dr. Subodh to give the vote of thanks, I have some two slides to. So people, can you see my slides?
Yes.
Yeah. So people who want a certificate, participant certificate, they can log in to the same nesiwebinar.com and can get a participation certificate. This will be open for 1 month. Or if people have missed this, they can again go to the YouTube. At least they should see half an hour. Then they'll be allowed to download a participation certificate. And the certificate is given by both NESI and WFNS Education Committee together. So people interested needs to download the certificate. All the webinars which we do monthly are there in this website, in the YouTube. It's called Neuroendoscopy Webinar Series, and each one can be viewed. So whoever have missed the earlier ones can go to the YouTube channel Neuroendoscopy Webinar Series 2 and can view the earlier webinars. As I told you, one has to to participate certificate. The certificate can be downloaded for 1 month. After that, it will be inactive. So people are interested, please do it early, and one has to watch the program for at least 15 to 30 minutes to download a certificate. I request Dr. Subodh to please give the vote of thanks.
Thank you, Dr. Manas. It was a very interesting session on hydrocephalus difficult situations and how to do this. Got some new insights into it. For that, I would like to thank Dr. Artur and Dr. Professor Sufiana. And each of the case presentations done by all three of our speakers were good and unique in this situation. And it always is a learning process in neuroendoscopy with newer and newer techniques and newer innovations. I also thank our panelists, Professor Ashish, Dr. Sankla, Dr. Devpujari, Dr. Venkatamna, and last not the least, Dr. Luis Bova from the WFNS Neuroendoscopy. And with this, we thank you all. And we will be meeting again next month for the next edition of the neuroendoscopy listings. It will be on 21st because 28th will be having the pediatric neurosurgery conference simultaneously. So I think the next series will be on 21st of January. We will be sending an email on that. With that, I thank our host and people who have made it convenient for this organizing this webinar. Thank you very much all.
Thank you.
Thank you. And
bye-bye.
Thank you.
Merry Christmas.
Bye-bye.
Merry Christmas.
And